Hi, everyone. Welcome to our AC Forum webinar on updates from the 2024 American Society of Hematology meeting. Thanks for joining us today. We have a great slate of folks to talk to you about some important anticoagulation-related topics. I'm going to be one of your moderators today. My name is Jori May. I'm an assistant professor for the University of Alabama at Birmingham. I'm an adult hematologist. I'm going to be joined in moderating by Andrea Van Beek, who's a nurse practitioner for the Anticoagulation and Thrombosis Service at Visalia Medical Clinic and Adventist Health Physician Network. Andrea is going to be monitoring the chat, so you may see her typing away, and she'll join us for questions at the end. And then we have three fantastic presenters today, all who presented at the American Society of Hematology meeting and who will be giving us a rundown of their presentations in brief. We have Deborah Siegal, who's an associate professor of medicine at the University of Ottawa and a scientist at the Ottawa Hospital Research Institute. We have Avi Leader, an assistant attending physician for the hematology service at Memorial Sloan Kettering Cancer Center. And then we have Joseph Shatzel, who is an associate professor of medicine and biomedical engineering at the Oregon Health and Science University. Two notes to make. We've all spoken before this webinar and have decided to refer to each other through first names throughout our conversations with each other. And the second thing is some of our presenters are actually battling viruses, as many people are this time of year. So there may be some sniffles and tissues. But I can assume that some people in our audience are experiencing the same thing. So hopefully everyone will be feeling better soon. So with that, I'm going to go ahead and pass it over to our first speaker. And Deb, take it away.
Thank you so much, Jori, and thanks for everybody for attending. As mentioned, I'm Deb Siegal, and I'm going to be talking about measuring the effect of direct oral anticoagulants, why, how, and when. And this was a presentation that I gave at ASH in collaboration with Dr. Siraj with Mithawani, who is from McMaster University. And we published an article, which with the citation shown there for the full-length version. And if you want a full-length version of the presentation, feel free to email me, and I'm happy to distribute that. So let's get right into it because we have limited time and there are so many important things to talk about. But I know that this is well known by the audience here is that DOACs are not routinely monitored. And that's because they have predictable pharmacokinetics, they're administered in fixed doses, they have a wide therapeutic index, particularly compared to warfarin, and they have no food and few drug interactions. We don't monitor these drugs routinely. However, there's a bit of a delay here, but measurement of DOACs or direct oral anticoagulants may be desirable if the results would change management. And so with this presentation, I'm going to provide you with our version of an approach to considering the measurement of DOACs in routine clinical practice. And I think this, if you take away not many things from this presentation, just the opportunity to reflect on whether or not these tests will change management, I will be a happy person. So of course, we're also quite familiar with some of the measurement challenges that are faced when thinking about measuring DOACs. First of all, there are no established therapeutic ranges for these drugs. Again, they were designed to be administered in fixed doses with no monitoring, right? So we don't know what therapeutic levels are. And when we do test, there's high variability. And I'm going to be talking a little bit more about that in the next slide. We also don't know what the threshold is for a clinically significant anticoagulant effect. And so there are consensus thresholds out there, 30 to 50 nanograms per mil has been proposed based on pharmacokinetic data. And this is, again, endorsed by societies like the International Society on Thrombosis and Hemostasis. But again, no clear evidence that for a hemostatic defect at certain levels. 3, coagulation tests that are routinely conducted, like INR and prothrombin time or PT or APTT, are not quantitative. And specific tests, which can be used to measure the level or quantitate the level of drug and concentration, are actually limited, both in terms of geography and also with turnaround time. So the final measurement challenge is really, what do we do with the results of these tests? Because of course, these drugs were not designed to be dose adjusted. So now we have a result, what do we do? And I'm sure that many people in the audience, like me, have thought many times, what do I do? Like, why did I measure this test? I opened this can of worms and now I don't know what to do. So hopefully people can relate to that. So here we're talking about why do we measure the effect of drugs that don't require measurement. And so here are some commonly cited reasons. This isn't exhaustive, but maybe to guide the use of reversal or of hemostatic therapies for bleeding patients or patients who need urgent surgery. Perhaps we want to know how much drug is in circulation so we can delay surgery until the drug is cleared so it can be safe. Perhaps we want to know about adherence after a breakthrough thrombotic event. Maybe assess for drug accumulation, like in the setting of renal impairment or other, metabolic abnormalities, or finally, to assess drug absorption, like after bariatric surgery or other kinds of gastrointestinal procedures that may impair absorption. But again, the key here for me is, does or should the testing change management? And so why are we even kind of talking about measurement? Like, why does it matter? And I think it's because some studies have shown that, in fact, there are relationships between DOAC levels and clinical outcomes. And so these three graphs are taken from two studies in atrial fibrillation. The ones on the left are from the RELY study, and the one on the right, which is dabigatran versus warfarin for AFib. And the one on the right is from the ENGAGE-TIMI AF trial, which is edoxaban versus warfarin for AFib. And what you can see is that the trough DOAC concentration, so dabigatran on the left and edoxaban on the right, are associated with outcomes. So at low trough levels, there's an association with an increased risk of stroke, whereas at high trough levels, there is an increased risk of bleeding. But importantly, as I mentioned, we don't have data to guide measurement and individualized dose adjustment based on the results of these tests. So we don't actually know what to do with the drugs themselves in a given patient at a given time. And so if there are no established DOAC therapeutic ranges, then what do we do? And I think this table shows, I'm not going to go through it in detail, but shows the levels of DOACs that are measured in people who are taking these drugs from pharmacokinetic and other studies. And you can see that in the middle column, we see the expected peak plasma concentration and the median, and then the 5th to 95th percentile, right? And so on the right-hand side, you can see the expected trough plasma concentrations, the median, and then that 5th to 95th percentile. And I think what you can appreciate from this table is that these levels are variable among treated patients. And so instead of using a known therapeutic range, what we have here is an expected on therapy peak and on therapy trough, the average or median here, and then the spread around that, or 5th to 95th percentile, which may be able to help us interpret the results of the test that we do. And so just to take the point home a little bit further here, what we see when we measure DOACs is that there is there's high variability both within an individual patient and between patients. And it's important here, people may or may not be familiar with the coefficient of variation, but this ultimately, it indicates the size of the standard deviation relative to its mean. So the higher the coefficient of variation here, the greater the dispersion around the mean, or the greater the variability. And I think what you can appreciate here from the numbers is that if we look at inter-individual variability on the left, we have 46% mean coefficient of variation at peak and 63% at trough. That's a huge variation, which makes it even more tricky to interpret what these results mean. And so what some have proposed, and I credit Dr. Suker with introducing me to this slide and this sort of conceptually, we have this on therapy range, which we can use. Again, we had that average concentration with the 5th to 95th percentile, as you can see here. And so what we can see is that in the middle, between the 5th and 95th percentile, we have this so-called on therapy range. And then anything below the 5th percentile is below the on therapy range, and above the on therapy range would be above the 95th percentile peak level. So it's helpful for us to measure a level and then compare it to that table that I showed you before to understand where that level falls within this range. And you can use this clinically. So how are we going to interpret coagulation tests in patients treated with DOACs? Now, this is even trickier because we know, as I mentioned, and many of us in the audience are familiar with, the fact that routine coagulation tests can be affected by DOACs, but aren't necessarily sensitive enough for us to really rule out important or clinically relevant concentrations of DOACs. So it's critically important. For example, if a patient comes in bleeding, they get routine coagulation tests measured, you're going to get a result. So it's important to understand, the limitations of those tests, and very important to understand the timing of the last dose relative to when the test was measured, and to estimate the drug clearance based on, kidney and liver function, etc. So what you can see in this table, I'll just kind of go through it very briefly, is this below, on, and above on therapy range here, as we talked about in the previous slide. And these colored bars represent the approximate range of detectability of each assay. So you can see that in blue here, for the thrombin time, which is TT, the thrombin time is extremely sensitive, well down into this below on therapy range. And the hatchings here represent the linearity of the assay with the DOAC concentration, so how well it lines up with that concentration. But I think what you can appreciate here is that for some of the other tests, they're not sensitive enough to rule out clinically significant or on therapy levels. And I'm showing that here with the dark blue. So if we have a person on rivaroxaban and the PT is normal, it's possible that they have a level in this on therapy range, and we're just not detecting it because the assay simply isn't sensitive enough. So if the test is abnormal, that might be helpful. But if it's normal, your assay simply may not be sensitive enough for us to understand whether or not there's clinically significant levels of drug in circulation. And this is a similar type of graph from a meta-analysis that I did with Dr. Suker and others, just to show a similar type of assessment here, but we're looking at now the specific DOAC assays for each of those drugs. And you can see that for each of these assays, the ones that measure dabigatran, rivaroxaban, and apixaban, you can see that they are sensitive well across these ranges of concentrations and are also linear across the range of concentrations, which is why we can use them to quantify or quantitate drugs. But again, tricky because we know that we don't necessarily know what those levels mean in terms of a hemostatic impairment. So when to measure a DOAC level, and this to me is like kind of the crux of this whole presentation, the clinical utility of testing. And we struggle with this because of course, there's this endless, what can we do, what should we do paradox in medicine. We can do lots of things, but the question really is, should we? And so ultimately the clinical utility depends here on the goal of testing. So are we wondering about impaired hemostasis in the setting of bleeding or surgery, or perhaps a patient who needs thrombolysis? Are we worried about excessively high levels in bioaccumulation with a drug interaction or perhaps renal impairment? Or are we worried about excessively low levels in the setting of breakthrough thrombosis or malabsorption? So I'll just illustrate here a little bit about how this can work in real life, where we have, if we're concerned about impaired hemostasis, of course, the priority is always rapid treatment, and we avoid delays waiting for testing. Okay, we can detect clinically when people took their last dose, what the clearance is like. We have an assessment clinically about the likely presence of clinically significant levels of drug. But this is a kind of an emergency situation where we want to assess for clinically significant levels. And here are some examples: bleeding, surgery, reversal agents, procedures, thrombolysis. And so we want to do a qualitative or a quantitative assessment. And so we can measure a level, and if it's above 30 to 50 nanograms per mil, then consensus guidelines would say that that's probably clinically significant. But if we can also measure a level and determine whether that it's in the on therapy range. That's very helpful, okay, to know, because we can say, between the 5th and 95th percentile, that person who's bleeding, who needs surgery, has levels that are consistent with on therapy range, and those are likely clinically significant. Similar things for excessively high levels. If we're going to assess for above on therapy levels at this point, so patients where we're worried about a drug accumulation in liver disease or renal disease or a drug interaction, we can measure a level, and if the level is in that above on therapy range, like above the 95th percentile, then we can at least reasonably conclude that level is in excess. And then finally, for excessively low levels, it's a similar type of situation. We can measure a level. We do a quantitative assessment for patients where we want to know if they have below on therapy levels. Again, a drug interaction or maybe a GI surgery or adherence would be a scenario. So by measuring a level and comparing it to what we expect the on therapy range to be, we can make an assessment of these types of levels. So I just included this at the end here. This is in the publication itself, and it kind of walks through some of the interpretations of the different routine coagulation tests, and then also drug-specific assays to help guide folks about the likely presence of clinically significant levels of drug. And just as I'm wrapping up, I'm going to leave you with this slide, which was Archie Cochran. Test only if it will change management. Before ordering a test, decide if what you will do if it is 1 positive or 2 negative, and if both answers the same, don't take the test. And so I'm going to leave these key messages up, and I'm thrilled to introduce my colleague and friend, Avi Leader, who is going to take us through his presentation next. Thanks so much.
Hi, thanks so much, Deb. So my name is Avi Leader, and while the slides advance, I will tell you that I will be talking to you today about management of anticoagulation in patients with brain metastases. And as Deb mentioned, I'm very happy to share the full version of this presentation presented at ASH, and I'll pop the link to the publication, which was written together with Dr. Eva Hameliak and Dr. Shlomit Joost into the chat a bit later. So let's get started. So these are topics that I'm going to try to address today. We'll start by trying to understand what the incidence of intracranial hemorrhage is in patients with brain metastases, and is this impacted by anticoagulation? And then if we're giving anticoagulation to these patients, is there a difference in bleeding risk between low molecular weight heparin and DOACs? And then moving through the risk factors for intracranial hemorrhage, we will try to wrap it up and understand how I would approach acute VTE management in a patient with intracranial metastases. So the first part of it is here. And if we look at retrospective cohort data, which is limited in quality, but is what we have, and we meta-analyze it, we can see two things. So if we look at patients off anticoagulation who have brain cancer, number one, intracranial hemorrhage is more common in patients with brain metastases than primary brain tumors. And there's a spectrum of this. So these may be micro, small, asymptomatic intratumoral hemorrhages, or there may be bigger intracranial hemorrhages. But at baseline of anticoagulation, it is more common in patients with brain metastases. And in general, if you have a look at the numbers in the blue box, they're quite high. So even patients with primary, with glioblastoma, for example, primary brain cancer, the incidence is at 6.4%, and in patients with brain metastases, it's 13%. So this is pretty frequent as of venous thromboembolism in these patients. And again, still looking at patients off anticoagulation, can have a look at this study to try and understand which patients have a higher, with brain metastases, have a higher risk of intracranial hemorrhage at baseline than others. And tumor type is a strong driver of this, with the two most studied tumors with a higher risk in this context being renal cell carcinoma and melanoma. So this is data from a cohort study shown on this slide, and on the right, you can see that patients of anticoagulation with melanoma and renal cell carcinoma have a 34% intracranial hemorrhage incidence over about 1 year, compared to patients on the left of the slide with non-small cell lung cancer, who have a much lower risk, but still high, at 19%. And sort of giving you a spoiler to what we're going to discuss in a second, you can see that when you match them to patients with enoxaparin treatment, the difference really wasn't, there really wasn't a difference in risk of intracranial hemorrhage. So that's sort of preview to what we're going to discuss very shortly. And so taking data, looking at patients on and off anticoagulation with brain cancer, we'll first look at patients with primary brain cancer, even though the focus of the lecture is brain metastases. And you can see here that across all of the retrospective studies and also in the meta-analysis of the data, anticoagulation is associated with an increased intracranial hemorrhage risk in patients with primary brain tumors. So this risk is about threefold when you summarize it, and it's pretty consistent across all studies. But then when you look at studies using the same methodology, a lot of them really the flip side and just looking at patients with brain metastases, you can see in the slide that there really isn't a signal for increased intracranial hemorrhage risk on anticoagulation versus off anticoagulation in patients with brain metastases. So there's something different between the two patient types and tumor types. And this does not rule out an increase in risk of intracranial hemorrhage on anticoagulation in patients with brain metastases. One would assume that there is, just using logic, that there is a risk, but it is not large and was not detected in these studies, which have their own biases, of course. And what you should keep in mind is that if you take additional risk factors for intracranial hemorrhage and you mix it in with anticoagulation, then maybe there is a clinically relevant increase in intracranial hemorrhage risk. And we'll talk about what those additional risk factors are very, very shortly. And I just want to use this opportunity to highlight that anticoagulation is not contraindicated in patients with brain cancer who do not have intracranial hemorrhage. And so we need to check that they don't have intracranial hemorrhage at baseline, and we'll discuss that in the management part of the talk. So now we're going to switch gears and talk about patients on anticoagulation. So these are patients who have an indication for anticoagulation, such as acute venous thromboembolism, and now need us to select the optimal anticoagulant. There are many things to take into consideration, but we're focusing upon the intracranial hemorrhage risk. And so we're going to talk about that now. So again, we're based upon retrospective cohort data, and this is a cohort of 745 retrospective cohort of 745 patients with brain malignancies receiving anticoagulation for any indication. So this is atrial fibrillation and VTE as well. Most of them had VTE. And we looked at the 12-month cumulative incidence of any intracranial hemorrhage. And on the left side of the slide, you can see the 505 patients with metastatic brain cancer, and that the incidence at 12 months of intracranial hemorrhage was 11.1% for patients on DOACs and 8.6% patients receiving low molecular weight heparin. And when we analyzed anticoagulation as a fixed variable and a time-dependent variable, adjusting for various risk factors, there was no difference in intracranial hemorrhage risk according to anticoagulation type. And in the primary brain cancer group, the findings were generally similar. There was actually a numerically lower risk of intracranial hemorrhage by several percent with DOACs compared to low molecular weight heparin. But I would interpret this as basically no difference and not DOACs being better. And when we look at the meta-analysis of the brain metastases retrospective cohort studies, including the one that I just showed you, one can see that it's pretty consistent in that there is no signal for an increase in intracranial hemorrhage risk with DOACs compared to low molecular weight heparin, and the ICH risk basically seems to be pretty similar across all studies. One has to bear in mind that there is a potential for confounding by indication, which means that patients with potentially who are more stable and have a lower intracranial hemorrhage risk would have been selected for DOAC treatment, confounding the results of these studies. But it does suggest that there is no clear, and these studies, even in the meta-analyses, may be underpowered to identify small increases in risk. And so we have to take that into consideration, but this is what the data is showing at the moment. There is no clear increase in risk with DOACs compared to low molecular weight heparin. And so I've been mentioning risk factors for intracranial hemorrhage and that we have to take them into consideration, but what are they? So I've attempted to summarize them here graphically, to summarize cancer-specific intracranial hemorrhage risk factors. So of course, there is a multitude of non-cancer specific risk factors, which we can look at specific guidelines for them. But these are the dominant things in cancer patients which one should consider. And the color coding that I've listed here is basically to show how which risk factors interact with anticoagulation. So for example, prior intracranial hemorrhage is specifically a risk factor for ICH in patients on anticoagulation. And VEGF inhibitors, for example, is possibly a general risk factor, here colored in gray, but it's uncertain whether adding anticoagulation to that further increases the risk of intracranial hemorrhage. So that's just generally how it's organized. And to go through them quickly, chronic kidney disease, VEGF inhibitors, and even stereotactic radiosurgery, specifically in melanoma patients for the first few days to weeks after the SRS, are potential risk factors of intracranial hemorrhage to consider. Cancer type is also important, as I mentioned. Two tumor types which I did not mention previously that are associated with increased risk of ICH are cholangiocarcinoma and thyroid cancer. But you can see that it's uncertain whether melanoma and renal cell increase the risk of ICH further with anticoagulation, whereas with high-grade glioma in the yellow part of the circle is associated with an increased risk of ICH with anticoagulation. It's important to look for antiplatelet therapy. We know that there are rare patients who need both full-dose anticoagulation and antiplatelet therapy, but we do know that the combination increases the risk of any bleeding and intracranial hemorrhage, and this is modifiable, so you should always check whether that patient is on antiplatelet therapy and whether that is needed, because that can be stopped in many cases. And thrombocytopenia is also something to consider, especially if it is below 50,000. And so this is some hypothesis-generating data. We try to look at baseline MRIs in the cohort that I just shared with you, 300 patients who had baseline MRI data available, and we were able to demonstrate that potentially certain imaging findings on baseline MRI, so prior to starting anticoagulation, may predict bleeding, intracranial hemorrhage within 12 months. And these include intratumoral siderosis, so this is microbleeding, evidence of previous bleeding inside the tumors, and evidence of small vessel disease, such as cerebral microbleeds and cerebral small vessel disease burden, were all associated with an increase in intracranial hemorrhage. And this is just food for thought and hypothesis-generating data, and not something that we can act upon at the moment. But it'll be very useful to be able to stratify which patients are at higher or lower risk of intracranial hemorrhage, because this is one of the things that we take into account when managing a patient with acute VTE and intracranial hemorrhage and intracranial tumors. So the very last part and slide of the study is to quickly go through how one would manage such a patient. So first of all, we need to assess the risk of ICH. We've spoken about the risk factors, but importantly, as alluded to previously, in patients who do not have recent brain imaging, I perform a non-contrast brain CT at baseline. Recent could basically mean in the last two weeks, 2 to 4 weeks, just to make sure that they do not have ICH at that stage. And then if the patient is at low ICH risk, meaning no ICH risk factors and no signs of recent ICH, we can use full-dose anticoagulation, whatever the thrombotic risk is. If the patient is at an intermediate intracranial hemorrhage risk, meaning 1 or 2 intracranial hemorrhage risk factors, but no active intracranial hemorrhage, we look at the thrombotic risk of the patient. In patients with low thrombotic risk, but concern for intracranial hemorrhage risk, we may consider a low threshold for AC dose reduction. And when I say low thrombotic risk, I mean patients with isolated distal DVT or isolated subsegmental PE. And in those patients with isolated distal DVT, we may consider low anticoagulation dose reduction or serolow extremity ultrasound Doppler. And in most patients with intermediate to high thrombotic risk and intermediate intracranial hemorrhage risk, we would consider full-dose anticoagulation for most of the patients. So this would be APE that is not subsegmental. In rare cases, we may consider reduced dose anticoagulation if the risk of intracranial hemorrhage is considered to be very high, and it is an upper extremity DVT, for example. That will be the minority of the cases. And the last part is a patient with an active intracranial hemorrhage, either symptomatic or identified on baseline CT screening. In those patients with a low thrombotic risk, we would hold the anticoagulation. In patients with intermediate thrombotic risk, we would also hold the anticoagulation. And in patients with high thrombotic risk, such as central PE, we would hold the anticoagulation. But if the volume of the intracranial hemorrhage is smaller, below 10 millimeters, we may consider reassessing in 24 to 48 hours for stability in case of a high-risk PE, and then considering starting prophylactic dose anticoagulation and then repeating the CT after several days, 24 to 48 hours, as a stability scan, just to make sure that the ICH is not expanded. And so, for the sake of time, I'm going to, I'll run through the slide, which is just a quick general overview that if we do go forward with full dose anticoagulation, there are certain specific factors that you want to consider in patients with brain cancer. They may be receiving anti-seizure medication or other medication which have interactions with DOACs. They may have dynamic thrombocytopenia due to their drugs. They may have issues with oral intake or impending surgery, for example, and all those may drive you towards low molecular weight heparin. But otherwise, you should use general guidance for cancer-associated venous thromboembolism to select whether you're going to be using a DOAC or low molecular weight heparin. And with that, I will leave you with this summary slide, and I will hand it over to the next speaker, Joseph.
Good morning, everyone. It's my real pleasure to present this talk for you today and to have presented this at ASH. I'm going to speak on hematologic complications in transgender care with a focus on what the hematologist should know. So some background, about 1 million people in the US identify as transgender. It's about 0.6% of the US population. And for medical therapies, they take a lot of dimensions. Gender-affirming hormone therapy is a medical therapy that can have hematologic complications. Patients are also offered surgical interventions, and that can lead to hematologic complications, including thrombosis and bleeding. And it's important to note that gender-affirming therapies reduces levels of depression and suicidality in patients, and it's very important to select patients' overall well-being. So, well, I broke this talk up into two sections. The first half is on estrogen, and we'll go through an overview of estrogen and gender-affirming hormone therapy, but we'll also focus on the data in cisgender women, where there's quite a lot of data because it's been studied as part of birth control and hormone replacement therapy for many decades. And we'll go over what data we have available in transgender individuals. We'll talk about ways to reduce risk of VTE, how to manage patients who develop VTE on gender-affirming estrogen, and then some peri-op considerations. So some key principles: estrogen at any dose does increase the risk of thrombosis, but the risk really differs based on the formulation and route. We'll go through that a little bit. And this risk is additive, so patients who already have high risk get this estrogen adds on top of it. Unfortunately, our risk of thrombosis increases as we get older, so age itself is a risk factor. And in some ways, the past predicts the future. So people with a prior history of thrombosis, unfortunately, carry a history, an increased risk of having a second thrombosis. Let's look at the data available in cisgender women. So in general, estrogen use increases the risk of venous thrombosis about threefold, and this is data from oral contraceptive pills. So it goes from 1 to 3 in 10,000 to about 3 to 6 in 10,000. This risk really changes based on the generation of pills used, with the first generation having quite high risk, as well as third generation with the progestin component. If you look at some of these odds ratios from this older publication, first generation oral contraceptives had an 8-fold risk compared to no oral contraceptive use in regards to venous thromboembolism. But that risk is still present, but smaller if you look at other generations, including second generation, where it's 2.8, and overall right around 3. This is from a publication we did with my hemostasis thrombosis fellow, Tom Kartika, but we just attempted to kind of stratify the risk of venous thromboembolism from different estrogen products. This data is almost entirely in cisgender women, but you'll see that some of the formulations carry quite a high odds ratio. When you get to progestin-only products, there's no increased risk. I think the big takeaway here is that transdermal forms of estrogen seem to have the lowest risk relative to oral forms. Their risk may still be increased, but the odds ratio is a lot lower than some of these earlier oral contraceptives. What's known about arterial disease? So in general, and this is from data from women who use estrogen as hormone replacement therapy, the estrogen use increases the risk of myocardial infarction. It's synergistic with other arterial disease risk factors like smoking. Same is true with stroke. And these risk factors are synergistic, like age and smoking will increase your risk when added with estrogen. Be that as it may, the absolute risk of arterial events remains low, about 1 to 2 in 10,000. So what is known in transgender individuals? So in general, oral estrogen does seem to increase the hazard ratio for venous thrombosis versus both cisgender women and cisgender men. I will say that this risk is often not observed with transdermal forms of estrogen, but the absolute rate still stays very low. So one of the largest studies, a meta-analysis of 11,000 transgender individuals receiving oral estrogen, reported an absolute risk of about 2 per 1,000. Now let's take a look at some of this data. So this is transgender individuals and their risk of venous thromboembolism compared to cisgender men on the left and compared to cisgender women on the right. And you'll see in both cases the overall risk of venous thromboembolism when starting estrogen increases. So what's known about arterial events? This data actually looks less concerning. Transgender individuals receiving estrogen may actually have lower rates of arterial disease compared to both cisgender men and cisgender women. So at least one large study of 12,000 transgender individuals found a lower rate of stroke and modestly decreased incidence of cardiovascular disease, particularly MI, compared to cisgender women. And here are the same curves, and you'll see that the curves are essentially on top of each other. So it does appear that at least for arterial disease, the risk may not be there with estrogen use in transgender care. So how would you approach the risk of thrombosis in someone who wants to start gender-affirming estrogen? There are only so many modifiable risk factors you can counsel on. BMI is a risk factor for venous disease if high, smoking for arterial disease. Certainly we can all counsel on arterial risk factors like diet and exercise. The type and route of estrogen use does seem to impact risk, with transdermal estrogen formulations having lower risk of venous thrombosis than oral. And the dose, which is generally not managed by the hematologist, and not my practice, it's usually the endocrinologist, but the Endocrine Society recommends keeping serum estradiol levels around the physiologic range for cisgender women. And that's one consideration. This is extrapolated, but people may surmise that this will cause less hematologic complications. A big question I get asked is, should patients have aspirin or a DOAC to prevent a first clot? I say there's no data on primary prevention until there's anything convincing, we don't routinely use it in this population. How do you approach patients who already had a venous thrombosis? So the key fact I'd like to leave you with is that individuals who have a venous thromboembolism while receiving estrogen can continue the estrogen if they continue the anticoagulation concurrently. This was shown in a lovely study by Martinelli and colleagues. So that has been our practice. If someone develops a VTE on gender-affirming estrogen and they wish to continue it, we continue a DOAC concurrently. And some people do choose to stop the estrogen, and then we view it as a provoked thrombosis and do 3 months of anticoagulation. Surgical management. So the number of gender-affirming surgeries performed annually is increasing. There have been a few studies on this. I just selected one. Because the question is, should patients hold their estrogen product perioperatively to help mitigate any risk of post-op VTE? At least one study looked at about 200 people who did versus didn't and found no change in the venous thromboembolism rate, which was very low. There was only one VTE in the cohort that suspended estrogen. So based on this and sort of the concept that it takes a while for your body's coagulation milieu to shift after stopping estrogen, probably longer than a week or two hold. We don't mandate patients hold their estrogen during around elective surgeries. So in summary, cisgender women do have an increased risk of venous and arterial thrombosis with estrogen. Transgender individuals do seem to have an increased risk of venous thrombosis compared to cisgender men and cisgender women. The risk of arterial disease, however, is unclear. It might actually not be present, or the hormone therapy may be protective in some way. We think it's reasonable to discuss risk factor reduction with your patients, but there's no evidence for primary prevention. Patients who develop a VTE can continue the estrogen if you continue a DOAC concurrently. And the surgical risks appear low, even with estrogen use. And although small data, it does suggest you can continue the estrogen perioperatively. Now I want to quickly go through testosterone. We'll talk about the data in cisgender men and transgender individuals. And then we'll talk about management of polycythemia. And to preserve time, I probably won't touch on iron deficiency today. So what is known in cisgender men? So meta-analysis show that there's no increased risk of venous thrombosis with testosterone use. It doesn't appear to be a strong VTE risk factor. However, many patients develop polycythemia. It's the most common adverse event. And the hematocrit seems to rise in a dose-dependent response. And the clinical implications of this polycythemia are understudied. It is unclear what risks this impart on people. So what is known in transgender men, the data concurs. There doesn't appear to be a VTE risk or thrombotic risk in general with testosterone use for gender-affirming therapy. Although the risk of polycythemia is definitely there, and the rate's similar to that seen in cisgender men, it's about 15 to 25%. So here's some real world data. This was a study we published from our own cohort of 923 individuals. So we found it took a while to reach peak hemoglobin in our cohort, about 31 months before patients reached the highest hemoglobin hematocrit we had reported. It depends on how you define polycythemia. If you use a hemoglobin of 17.5, the rate was about 8%. However, if you use a hematocrit above 50, you'll see the rate was much more striking. What was the management strategy used at our hospital? Well, it was provider dependent, but the most common was dose reduction. About 5% of people received a phlebotomy. We had a very low rate of thrombotic events, less than 1% in that cohort. So how do you approach polycythemia in these patients? There's 3 options. None are evidence-based, and no one knows what to do. But you can observe, because there doesn't appear to be, at least as we know, a risk like there is with polycythemia vera. I think much more commonly and in line with kind of the cisgender guidance, patients get a dose adjustment. Either they have a dose pause, decreased, or a formulation change. Phlebotomy is an option, but it definitely causes iron deficiency. I do wonder if it makes people's quality of life worse. So similar to estrogen, there's some data that transdermal testosterone causes less hematocrit elevation, and that's a consideration. Phlebotomy is understudied, and it definitely causes risks of iron deficiency. At least at a minimum, we kind of suggest assessing ferritin levels in patients and discussing with them. Our experience has been that when patients develop polycythemia in the setting of testosterone, they also develop iron deficiency. So my last slide, and then I think we'll open for Q&A. But in general, there's no apparent risk of thrombosis with the use of testosterone in cisgender men, but erythrocytosis is common. The same is true in transgender individuals, no thrombotic risk, but erythrocytosis is common. How to manage it is unclear and is not evidence-based. Your options are to observe, adjust the dose, which tends to be the more common avenue in our hospital, or a phlebotomy, which is comes with its own complications. And the rates of iron deficiency in this cohort are essentially not described. I think that would be a fascinating study if anyone on the call is interested. So with that, I think we'll end the seminar, and I believe we open for questions.
Great. Thank you so much to our fantastic presenters. All important topics and full of information in a very brief period of time. We made them condense their ASH presentations in half, and I think they successfully did it. So thank you. So lots of questions coming in, lots of already answered been in the Q&A. So if you want to browse those, but I have some questions here that were submitted prior to the presentation that I think are relevant. And I'll start with one and for Deb, but really for the whole group. And the question is really about the availability of obtaining levels. You are in Ottawa, so your experience may be different, and interested to hear from others. But how widely available are these assays? If you're sending them, how are you sending them? Just kind of the practical pieces of, if I wanted to send a DOAC level, what are the different ways that happens at different institutions?
Thanks so much. Really good question, because I think this speaks to like what is available at my institution. And it's quite variable in Canada, so I am not representative of all Canadians. We do have the availability to do calibrated assays for dabigatran and apixaban and rivaroxaban, and we can measure those. There's a variable turnaround time, so that's something that's really important to consider. How long is it going to take for you to get a result at your institution? If it's a send out, obviously that's not something you're going to be able to do, for an emergency. So whenever we talk about these kinds of levels and measuring them, it's always in the context of like, again, why am I measuring, and like what information is this going to help me? What decision making is this going to help me with? And so in an emergency, if it's a send out, not helpful. But if you can get that back within 15, 20, 30, 45 minutes, and some people can, then it might be helpful, right, for you to make decision making in real time. What we don't want to see is people delaying treatments and making treatment decisions that are delayed because they're waiting for some test. If we want to know if a person has clinically significant levels of DOAC and they're bleeding like in a life-threatening way, or they need urgent surgery, then we're going to find out when they took their last dose, understand their, drug clearance with kidney and liver function, and kind of, really if they've taken their last dose within the last 24 hours, which is like 2 half-lives, that's probably clinically significant levels for those scenarios. So we don't always need to do testing, and we particularly shouldn't delay like life-saving treatments for those investigations. It's like my little soapbox thing.
Thanks, Deb. I'll ask the next question. I think this one's going to be for Avi. This one came in on the chat. There was a question about the most appropriate VTE prophylaxis for patients with those high-risk cancers, like brain mets from melanoma or renal cell carcinoma. Not talking about VTE treatment, but VTE prophylaxis. What kind of an angle do we take if they're very high bleed risk, but obviously we still want to prevent clots, especially in a patient who might be hospitalized or post-op from surgery, et cetera?
Okay, yeah, it's a very good question. So let's assume that I'm not going to talk about the indications for VTE prophylaxis, just you mentioned some of them, and so the assumption will be that there is a good indication for that, because that's a whole separate webinar. But so assuming that there is a good indication for that, I do not think that but barring previous intracranial hemorrhage or active intracranial hemorrhage, having brain metastases, even if they are potentially at high risk of bleeding, is not a contraindication and not a reason not to give that. Now, you could also rationalize the flip side of it. If those are patients that you would maybe want to not give full dose anticoagulation, even though you can, so this could prevent it. And I just want to take this opportunity to emphasize that we do not know that even full dose anticoagulation increases the risk of bleeding in these patients. I mentioned that it may, and that with additional risk factors, et cetera, but it is not a clear thing as it may be in patients with primary brain cancer. So for glioblastoma multiforme, for example, there is a randomized controlled trial showing that primary prophylaxis for all comers actually increase the risk of bleeding, and so there is a concern over there, and sort of a different talk, but it emphasizes the difference between these two groups.
Yeah, I think you bring up like an interesting point about anticoagulation stewardship and how we as anticoagulation providers, which many of us on the call are, things that we can do to mitigate that bleeding risk, things like deprescribing antiplatelets, keeping patients off NSAIDs, thinking about concomitant drug-drug interactions. And so, highlighting all of the things that we can do as frontline professionals taking care of these patients and their drug state and, making sure we mitigate the risk to the very best of our ability. So,
yeah, I agree 100%.
Great. Well, I'll dive into another question that was submitted, and this one will go to Joseph. And the question is about the VTE risk with testosterone. You touched on this and basically kind of gave the summary of, in general, in cis and in transgender people, that we don't see an increased risk with testosterone. But I think there is kind of the traditional lore of all, testosterone and estrogen all come with an increased thrombotic risk. So I wonder if you could expand on that a little bit more, maybe your understanding of the data and how you've reached that conclusion.
Yeah, thank you. I have had many providers approach me with concerns about that. And all I can say is that there's a lot of published data on cisgender men. And in general, I would say the majority of studies don't show any risk. There's some meta-analysis that might suggest a small risk. I know of only one. But there are many studies that show none. And I can only say that the data in transgender individuals is a lot smaller and it's less robust. These are not prospective clinical trials. These are cohort studies, really, that people are just taking everyone who received testosterone at their institution. And that's what we published. And I can say in those cohort studies, the rates are very low, like on par with the background rates in the population. So I've been convinced by the data. I don't feel that patients are imparted a risk. I think the looming question that's unknown is if patients take testosterone and get a very high hematocrit and ignore it, perhaps they're using testosterone unmonitored. Are those patients at higher risk? And I don't think we know. I think we assume from polycythemia vera that high hematocrit increases thrombotic risk, but with medicine-induced polycythemia, it may not be true. So that's where we leave it. I definitely don't leave people with severe polycythemia. I recommend they adjust something to address it.
That's helpful. I think that's the challenge of caring for many of these patients, is there's so much nuance and not an 100% clear right answer in the risk that comes with these treatments. But your summary has been very helpful. Andrea, do we have anything else from the chat?
I sure do. Avi, I have a question that came in. When we think about patients with brain cancer or brain metastases, and we think about their bleeding risk, we have this induction dosing typically at the onset of, DOACs when we have a new VTE. Where do we typically see, as a clinician, what time frame should I be most concerned about risk for a bleed in the brain? Is it typically during that induction period? Is it in the first 30 days? When should we have our spidey senses, the most alert for this type of a problem?
So yeah, that's an excellent question. I mean, it's something that we discussed a lot in our group, and we were writing these various papers on guidance in the situation. And when you say induction, you mean the increased dose during the first week or first 3 weeks, depending on which DOAC, right?
Exactly.
Yeah.
Exactly.
Okay, so I mean, So first of all, when is the risk increased? With all bleeding, it's usually top heavy. So with all bleeding in cancer, in general associated with anticoagulation, it's usually top heavy. So it's a lot of this happening more in the beginning. And so this is exactly the period in which one should be more concerned. And also when the cancer is active, this speaks to another question that I answered in the chat. You know, in the beginning, the cancer you would assume is active, and maybe it's newly diagnosed brain cancer, the cancer is being treated, and that will also decrease the risk over time. So yeah, that's the high risk period. And the other part of the answer is, you know, it's maybe easier to manage bleeding if it happens on low molecular weight heparin than on DOACs, sort of linking into what Deborah's been discussing, but not only. And so my feeling, if it is an active patient, and that's not even looking on the induction question, but if it's an active, very active patient who is at high risk, may need surgery, may need SRS, maybe I would prefer low molecular weight heparin. In the beginning, in those patients, this is my, not everyone agrees with me on my group, but this is my personal approach to get me over the first, let's say, week, or if it's a Apixaban, or 3 weeks, if it's a rivaroxaban, you know, difference between drug of the increased dose, because we don't really know what that does, and that may be an additional risk factor, you know, tipping the person over who is already at risk of bleeding. So that's sort of how I approach it.
Thanks. That's helpful. It's something we all worry about. Keeps us up at night. So.
Yeah.
For sure. Well, we could go on with questions forever, but unfortunately we need to wrap this up on relative time. So I'm going to go ahead and wrap us up. And I first want to thank our fantastic panel. So thank you, Deb and Joseph and Avi, and thank you to my co-moderator, Andrea. This was a really engaging conversation, and based on the number of questions that we received, clearly topics that are very relevant to those of us that are taking care of these patients in the front line. So thank you for all sharing your expertise. Just to highlight a couple of things that are upcoming. So if you like webinars, we have another one coming up. So this is going to be the February webinar on subclinical AFib. That's on February 11th from 12 to 1. Another thing to highlight is the AC Forum's Center of Excellence program. So a lot of you are anticoagulation providers. So I ask, you know, is your organization one of the 150 plus anticoagulation centers of excellence? So if not, I encourage you to look into this program and to think about applying. As a special acknowledgement, we're inviting all sites who passed the ACE assessment from January to March 31st of this year up on the stage to receive an ACE certificate at the Anticoagulation Forum 2025 National Conference in April. So something to look forward to, and maybe this is the right time for you in your center to apply. So keep that in mind. And that transitions us to reminding you about the National Conference. Hopefully this is already on your calendar, but this is going to be in Washington, D.C., April 3rd through 5th. It's going to be 3 days of sessions, over 30 expert speakers, a minimum of 14 hours of CE. So go ahead and register. There is going to be a price increase in around March for both registration and hotel. So join now, and hopefully we will get to see you there. And with that, we'll say goodbye, and thank you again to our panelists. Have a good day, everybody.